A disclaimer first of all. So what I've kind of come through is that these are scenarios I've come up with. They relate sometimes to a gold standard in terms of what we think should happen, but there may be differences in your local area in terms of what can and can't be done, and resources in different areas are going to be different. So although this is perhaps what we'd like to aim for everywhere, it may or may not be possible. And please don't change anything before checking with your local teams if there's something that happens in your specific area. Having said that, the National Genomic Test Directory should be followed in all areas. The point of that is that it's everywhere. And so the labs should all be applying the same criteria, essentially. So I was just thinking about the two main scenarios in a way. The first is that you've got a patient that's well known to their local fetal medicine team. Anomalies have been diagnosed on scan. And ultimately, the plan for this should really be arranged by the fetal medicine team, who should direct what goes on thereafter because they know the patient. So it may be that in these situations, you've got a confirmed diagnosis, and it might be genetically confirmed on an R21. It might be genetically confirmed as a microarray. It might be a trisomy. Or it could be something where it's an uncomplicated neural tube defect. We don't think there's anything else relevant. We think it's a sporadic disorder. In those situations, you don't need to offer a PM, and no further genetic testing is necessary, and that should be communicated through. The then ones that we probably get involved in are the ones where we don't have a diagnosis. So in those situations, they're the ones where the couples really should be offered a post-mortem, so we can try and get more information with the idea that we can try and work out what's gone on with this fetus. And I say PM with DNA storage. So this is where protocols might slightly differ in terms of whether your local protocol might be to send a piece of placenta or something at the time of delivery. Or alternatively, it may be that the pathologist, when they receive the fetus, they will take the sample and send it off to the laboratory at that point. So locally, what will happen locally with us is that if the PM findings suggest a likely genetic disorder, then they're referred to us. So here we have a MDT meeting with our pathologist, we review the cases, and we either say, actually, we think that looks very sporadic, we don't think that looks genetic, and the fetal medicine team will feed that back to the couple. Or we'll say, actually, we are suspicious there could be something genetic there. At that point, they're referred on to see us in clinical genetics, and we arrange the testing on the sample that's already been stored. If in that situation a post-mortem is declined, this is where it's really helpful to ask for an external PM, because some couples will agree to an external PM at least, and they will agree to an external PM with clinical photographs and X-rays and DNA storage, in which case that gives me at least some information to work with in order to do some genetic testing. So I thought it'd be helpful at this point to just say what we actually do in clinical genetics. And this is where, I don't know if my colleague Matilda is on the call, but I have a fantastic genetic counsellor that works with me, and all the referrals that come in this situation, we discuss and agree what's going to happen. So when the referral comes in, we review the phenotype. So that's the clinical picture of the baby. And that's hopefully from a post-mortem, because we've got that information, or at least from clinical photographs. And then we decide what the appropriate testing would be based on what that testing is. Or sometimes I will look at them and I'll go, actually, I don't think that's a genetic condition. I think that's very much a sporadic, much more likely to be just a one-off, and therefore we'll talk to the family and say we don't think it's likely to be genetic. If we only have a phenotype purely from the scans, it can be quite difficult. So we don't know what we can't see. We know there's limitations to fetal ultrasound in terms of what you can and can't see. Scans can be fantastic, but it's not the same as looking physically at the baby. MRI scans can be really useful, particularly because fetal brains can be quite tricky to look at a post-mortem, but if a family have had MRI beforehand, that can be useful. But we decide on whatever testing, and I will decide which testing is appropriate. So if you remember, we've got stored DNA in the lab at that point. I will decide whether I think we need a big R27 panel, or it might be a skeletal dysplasia panel because we think it's a skeletal dysplasia, or other alternative panels. Sometimes we, from the post-mortem and from our discussion group, we can see that it looks like a very, very obvious diagnosis. Occasionally we'll just pick a small gene panel or even single gene very occasionally, so we can get a result quicker for a family. Subsequent to that decision, my genetic counsellor colleague will speak to the family, talk them through the process, explain the whole genetic testing possibility, and consent them for whole genome sequencing if that's what they agreed to. And she'll either do that by phone or face-to-face, depending on where they live often. And when we do that, we usually need parental samples, because when you're doing whole genome sequencing, you need both samples. And then we activate that sample when we've got that consent. So no other testing started until this happened. So I think that's an important point to get across, really, is that it's possible that a microarray is done because it's requested earlier via your teams, but any further testing is not happened until we've got involved. And so the phrase that I hear where people say, "Oh, the genetics is normal," is a misnomer and doesn't make sense. The specific test they've had, the microarray might be normal. That doesn't mean to say there isn't an underlying secondary diagnosis that we haven't found because we haven't finished that testing yet. So if post-mortem is declined, firstly, it's possible that an external PM will be accepted, and some of ours do accept that. Sometimes some couples will accept clinical photography, X-rays and DNA storage. So I know within some religious groups, the concept that they need to bury the fetus quite quickly can be a bit of an issue. And often there are memory mating photographs made, which I have sometimes used to look at phenotype. But if they will agree to clinical photography, which a lot of couples will, those photos can be absolutely really essential in terms of me phenotyping and trying to work out what's going on. Because whenever I do genetic testing, when I fill in the form, what I put on the form in terms of what the clinical features and the phenotype of the baby is, increases the diagnostic rate for the greater chance of me getting a diagnosis. Because the way genetic testing in terms of whole genome sequencing works is that you filter out a lot of information, a lot of variants, and you do that based on the fact that maybe someone doesn't have that phenotype. So if you miss a phenotype and you miss a piece of clinical information off, the diagnosis may get filtered out. So that's where post-mortem or alternatively photographs, X-rays, etc., are absolutely crucial in getting to a diagnosis if there's a diagnosis to be found. And we use all that in our team. And if we've only got scan findings to go on, there may be things that we just don't know, because if you dissect a fetus, you might find some quite detailed information that there isn't a chance you would have found on a fetal scan. And of course, the main point of getting as a genetic diagnosis is to give them information, both for their own well-being, because I think knowing the diagnosis for families does massively help them in terms of coming to terms with things, but also if they're going to have more children, having an accurate recurrence risk and what the chances of this happening again, and then possibly prenatal if that's something they choose and if appropriate. Or you might end up saying it is genetic, but it's a de novo, it's a new thing in that fetus, and the chance of it happening again is low, and a lot of people won't have a prenatal in that situation, and they can feel very reassured by that. So I think those first ones are quite straightforward. In terms of the fetal medicine teams are often very much involved in that group and will direct what goes on, and I think that's really helpful. I think the second group, where the patient's not known to fetal medicine and you get an unexpected loss that nobody was expecting to happen, those are quite tricky. So in terms of postmortems and testing, I've split it up into two groups. So there's the unexpected loss less than 12 weeks. Essentially, the chances are great that those losses are random chromosomal events, but random one-off sporadic chromosomal events, there's a high chance of that happening. There obviously could be other causes, but that's although there isn't any testing that's appropriate or commissioned in that circumstance. If you've had 3 of those losses, on the 3rd loss, then you can offer genetic testing in terms of a microarray on the products of conception. So that is what we talked about before, looking at an overview of the chromosomes of the baby, looking for any chunks missing or extra, or any big trisomies that will explain things. And that is that code R318. And as I mentioned before, the losses no longer need to be consecutive, so it could be separate. So those ones are relatively straightforward, but again, we talked about it's important what's filled in the form as to what testing would happen. Then the second group is unexpected loss of greater than 12 weeks, but less than 24 weeks. Now, according to the national commissioning document, they should be offered PM, which might include DNA storage. Or it might be that the local protocol is to send DNA separately. But I've put here, unless we know there's already a diagnosis from perhaps NIPID or something, or something like an isolated neural tube defect or something, which is going to be a most likely sporadic event, and so therefore you don't need to do anything more with that situation. If the PM at that point suggests a likely genetic disorder, then the PM results need to be fed back by the obstetrician and then offered referral, and the processes will be the same as they were on the previous slides. If at that point the PM happens and actually it looks like a sporadic disorder, then the results are fed back by the obstetric consultant to say, yes, it was an isolated, it was something that looks like it's non-genetic, or it could be, the thing I haven't talked about hugely about is placentas, but it could be a placental issue, for example. And I'll mention those again in a minute. In fact, there we are. We're on placentas. So obviously my expertise is in genetics and genetic testing and issues with fetuses, but the other big issue is whether there's a problem with the placenta. And so there's 2 essentially bits of testing that might be done on placentas. The first is that the placenta may be sent. I'm not going to talk about which placenta they're sent because that is not my role or expertise, but essentially you send it to the histopathology lab, they look down the microscope and they're looking to see if there's ischemia, was the placenta functioning correctly, all those kind of things. Alternatively, the placenta may be sent to a bit of placenta may be sent to a genetics lab to do a microarray and DNA storage and or sequencing or whatever testing we do. So those 2 things are kind of separate things that you need to be aware of. So when we send a placenta off, you need to be clear whether you're sending it to histopathology for them to assess whether the placenta is an issue or whether it's going, that bit of tissue is going off to have genetic testing, and whether they're eligible for any genetic testing as per the previous slides. So that's that. So the next bit is unexpected IUFDs stillborn, so those greater than 24 weeks. So according to the commissioning document, they should be offered a post-mortem, including DNA storage, by the local pathologist, and they would be eligible for at least for a microarray. Local protocols might be different at this point in time, and that's why I said I know in one of our services they send them dry with the baby, or it may, I think locally we sometimes send a skin biopsy, so you might need to check on local processes, but they should be eligible for at least a microarray. If the PM goes ahead, then if the feature suggests a genetic diagnosis, so locally we would discuss it in our meeting and decide, and we would advise which ones need referral to us, and then we go through the process that we did previously. So I just wanted to discuss if postmortems are declined. So I think this is relevant. This is the one that's quite relevant in terms of thinking about what we do. And I think there's a group of families where it's quite tricky to know what you are supposed to be doing with them. So if they're eligible for a postmortem but they've declined it, in whatever setting it is an obvious cause known? Is there a placental cause? Do we know a genetic diagnosis? Straightforward neural tube defects, for example. If yes, then that can be counselled appropriately. If we don't know an obvious cause, but they don't want a full PM, would they agree to an external post-mortem? And then the next group is where it's tricky. So if no, they won't agree to an external PM, maybe they're not interested. I find that unusual, and I'm not sure there'll be many people in that group. But if there are people that don't want anything more to be done in terms of even a pathologist looking at a baby, the question is, is there anything obvious that suggests we are looking at a genetic disorder here? And if the answer to that is yes, then it may be appropriate to arrange clinical photographs, store DNA, and contact your local clinical genetic service.